We're here to talk about L5-S1 ALIF in the lateral position. Looks like we've got Dr. Thomas ready to go, so without further ado.
Not sure how I can follow up that talk. That was great. Master surgeon there. Those videos are really cool too. This talk was supposed to be given first, kind of introduction to this concept of lateral ALIF. I know a lot of you here are familiar with it. Some of you guys have been to Wilmington to watch us do it. But this is something that I'm very excited about. So I don't need to tell anybody in this room about the power of XLIF, lateral lumbar interbody fusion for spinal surgery. The minimally invasive placement of these large anterior intervertebral spacers allows for powerful deformity correction, powerful height restoration, and indirect decompression. This is a pretty typical case in my practice. Middle-aged patient with a mobile spondylolisthesis near grade 2. And you see pretty significant central stenosis, lateral recess stenosis. This is a patient that we just did a single position XLIF on without a direct decompression and did great. Single position XLIF with percutaneous pedicle fixation, it did great. I think a lot of people here would feel compelled to directly decompress that, but with the height restoration that you get with those spacers, I'm always surprised at what I can get away with in terms of indirect decompression. But again, I don't need to tell anybody in here about that. These are just some of the results that I looked at in my own series, almost 200 patients since 2013. And just like all y'all in here, excellent clinical results with XLIF for lateral interbody fusion. Very, very low case time, which I'll get to in a minute. Very low length of stay. Our average is 1.4 days, but it seems like these days most patients go home the next morning. And significant clinical improvement, no infections, and a very acceptable complication profile. The question is, what do you do about this case? This has always been the crux of XLIF, at least in my opinion. So this is another very typical case, I think, for a lot of our practices in here. This is a middle-aged male, mobile spondylolisthesis at L4-5, and then severe disc-based collapse and foraminal stenosis at L5-S1. This is a very common case, maybe even more common than just the isolated L4-5 problem. So in the past, I've tried to, I would always laugh at myself because I would value the power of these large intervertebral spacers and preach the importance of that, but only at L4-5 and above. I would come up with other solutions at L5-S1, do a T-lift. I even tried to do some T-lifts in the lateral position, which is not fun. In other cases, you try to talk yourself out of doing that level, right? You say, well, maybe that level's not that bad. Maybe it's already fused, and you try to talk yourself out of doing that. And I've been guilty of both. I'm certain that you guys aren't, but I have been, admittedly. But if you do care about the power of intervertebral spacers, this is what you do. You take the time and you do the right operation. You do the supine ALIF at L5-S1. You stop, close up, bring another table in, flip the patient. You do the XLIF, stop, close up, flip the patient. You do the posterior fixation. That's 2 flips there. And one of you in this room has come up to me and said, well, it only takes 5 minutes to flip at my hospital. I don't really care. That's great. I need to come watch that and learn. At my hospital, when I stand there in the room, it's 30 minutes at best. And I don't know about you guys, but that's the best we can achieve. So that's an hour right there, not to mention the danger to the patient of repositioning them twice. The anesthesiologists hate that. So, but again, this is what you have to do if you care about placing those intervertebral spacers. So as Bill has already eloquently shown, over the past year and a half, we've been developing this new retractor-based solution that allows you to do an ALIF, a true ALIF, with the patient in the lateral position. This is a demonstration of a case of a colleague here. You see similar to what Bill does with the kind of freehand mounted retractor blades. You have the option of using this carbon fiber arc to hold that lateral and cranial blade, and then the medial blade is mounted independently. And you get tremendous access with this, tremendous visualization, can get complete annulotomy and release, and get excellent height restoration and placement of a large spacer, just like an ALIF. And so this is not some novel thing, it's just an ALIF. Now, the purpose of this talk was kind of to talk about, well, when would you not do lateral ALIF? When would you instead do supine or something else? And I would caution you against thinking about that. This is, again, this isn't something exotic. If you can't do a supine ALIF, then you can't do a lateral ALIF. I can't think of a time that I've ever thought, this wouldn't be safe to do in a lateral position. We might as well do this supine. Now, there are cases where you wouldn't want to do an ALIF, right? So the same rules apply. Calcified vessels. We did have to bail on one a few years ago in a patient that was previously irradiated. We just could not mobilize the vessels. Arguably, you could have made that decision preoperatively with a little bit better history taking, but we did not, and we ended up having to bail on that. So the same rules apply for lateral ALIF. There are some cases that I wouldn't necessarily do as my first lateral ALIF. This is a patient that we've been following. Thank God she is responding quite well to conservative therapy, and we keep following her with physical therapy. This is a lady with a pelvic incidence of over 80, and I would say would be very challenging and maybe not possible. This might be the first one that we aren't able to get away with. But you can do it. This is not quite as severe of a slope, but this is a lady, a very active 38-year-old lady with an isthmic spondy, a near grade 2 slip on flexion, PI of about 75. So challenging. We did have to do some tricks in the operating room to make this happen. But as you see there, we were able to get a complete reduction. And this is a case that was done in about 90 minutes. Patient went home the next morning. So you can do those more, the steeper slopes, more severe slips. It just takes a little bit of extra effort. And again, I wouldn't jump into that as one of your first cases. But I think so it's excellent for transitioning from XLIF to lateral ALIF. Patients already in the lateral position. You don't have to move them. But I think, as Bill's already shown, stole my thunder. It's my fault because I didn't have the right talk loaded up. But this is when you really start to see the power, that you really start to realize the efficiency benefits of this. So this is a case probably about a year ago, standard L5-S1 spondy case with percutaneous pedicle screw fixation. And you see, this is the right side up. Jack, my PA, is on the front, still working on the front incision, and I've already got the wires in at the back of the patient. So you have concurrent access to the front and the back of the patient, and you can make dramatic improvements. So not only are you saving the flip time, but when you can start to work simultaneously, it's amazing what you can do. So it's not unusual these days to have a standard just L5-S1 perc screw case be done in 60, 70 minutes. And that's not me boasting. This is really what you can achieve with this efficiency. One of the colleagues here from NYU was sharing his experience with me. He's just started to do this. He's done about 10 cases, and he's already doing this in 60, 70 minutes. So it's what you can accomplish. This is just some data. Again, kind of a preview of some of the data that I'm presenting tomorrow. On the top there, you have some patients from our series basically over the past year. So the left column there is single position XLIF and percutaneous pedicle screw fixation. That's 75 patients. And then you have the single position lateral ALIF with perc screws, about 21 patients. Average case time for the XLIF and screws, 65 minutes in our series, 97 minutes for lateral ALIF. And that's actually 1 and 2 level cases, very low EBL and length of stay. And by the way, significant correction of lumbar lordosis. You contrast that with a recent study. This was a study published in the Spine Journal a couple of months ago, looking at minimally invasive TLIF or minimally invasive, or ALIF with perc screws. And this is a very good center, a TLIF center. This is, I think, Kern Singh's group up in Chicago. But look at the minimally invasive TLIF and perc screw case time. It's 252 minutes for a 1-level fusion case. ALIF, similar time, 241 minutes. High blood loss and length of stay, almost 4 days for the TLIF group. So compare that to what you can accomplish with single position, 360 robust, 360 reconstruction, and it's remarkable. And again, this is something that all of you guys can achieve in your ORs as well. It matters, right? This increase in your efficiency matters. Of course, it matters because if you want to, you can do more cases in a day. The hospital certainly loves you if you do that. My wife and kids love it because I get home at 3 o'clock after doing several of these cases. But we know from cardiac general surgery literature that time matters. Time under anesthesia matters. If you can save that patient an hour, or compared to this data, maybe even 2 hours of anesthesia time, that is significant in terms of patient outcomes. And I think over the next year or two, we're going to be able to prove that in the literature. The audio is not playing, but this is obviously a big guy. This is actually like one of the cases that we did when Dr. Pimento was here watching us. By the way, it's quite nerve-wracking to have Dr. Pimento watch you do an XLIF. But this is a 4-to-1 fusion case. This is about 2 hours after surgery. This is
Looking good. How long ago was your surgery?
Couple hours.
Good. We'd like to see.
I'm not sure what time it is.
not an easy case. Big guy, very sclerosed disc spaces, L4X, L4-5X L5-S1 lateral ALIF. And this is a very common outcome. We go up and walk the patients that day, and they all look like, most of them look like this. So that time that you save under anesthesia matters in terms of these patient outcomes. So I think that's all I have. I'm happy to take any questions later.